Hello and welcome to today's webinar, The Opioid Crisis, Perspectives from Addiction Specialists in Primary Care and Psychiatry. My name is Dri Wang and I'm from the Otsuka Medical Affairs team. I'll serve as the moderator for this exciting discussion featuring Dr. Matthew Torrington and Dr. Richard Rosenthal. Dr. Torrington is a family and addiction medicine physician in private practice in Los Angeles and the medical director of the Common Grounds Free Clinic in Santa Monica, California, where, among other efforts, he supervised opioid overdose prevention efforts. Dr. Torrington received his medical degree from Jefferson Medical College in Philadelphia, Pennsylvania, completed his residency in family medicine at Christiana Care in Wilmington, Delaware, and completed a clinical research fellowship in the Integrated Substance Abuse Programs at UCLA. He has received multiple awards for his community service efforts, is engaged in numerous research activities centered around addiction medicine, and is a distinguished fellow with the American Society of Addiction Medicine. Our second speaker is Dr. Rosenthal, is the Director of Addiction Psychiatry at Stony Brook University Medical Center, a professor of psychiatry at Stony Brook University School of Medicine, and an attending physician at Mount Sinai Hospital in New York. He received his medical degree from State University of New York, Downstate Medical Center, and completed residency in psychiatry at Mount Sinai Hospital. He is a distinguished life fellow of the American Psychiatric Association and past president of the New York Society for Clinical Psychiatry, serving on committees related to substance use disorders. He currently heads the public policy section of the American Academy of Addiction Psychiatry, where he is a past president and distinguished fellow. He has contributed to numerous clinical trials and grants aimed at creating a deeper understanding of mental illness and substance abuse disorder. Over the next hour, our speakers will be discussing the current opioid crisis and providing their perspectives on how we got here, the implications of the opioid crisis for mental health, and how the crisis and opioid use disorder can be addressed. Today's webinar is sponsored by Otsuka Pharmaceutical Development and Commercialization, Inc. and Lundbeck, LLC. We're committed supporters of the mental health treatment community. At this point, I will give the floor over to Dr. Rosenthal, who will begin with the quick overview of the opioid crisis in America.
Good morning, everyone. So I'm going to cover briefly a bit of the history of the opioids in the United States and some of the epidemiology of the current epidemic. And, really to start, I'm not going to go through everything in the slide, but, heroin was synthesized back in 1898 and started being marketed around the turn of the last century. And what happened over 10 or 20 years is that people started getting addicted to it. And so by 1913, commercial production of heroin was stopped. And in 1914, the Harrison Narcotics Act was passed, which really curtailed distribution and sale of heroin and opium products. Past that point in time, physicians having, sort of experienced the downside of opioids at that time, became very restrictive and conservative about prescribing opioids for pain. And so from the 1920s through the 1980s, there was really opiophobia, and pain, even acute pain, was really undertreated. And then in the 1980s, there were a couple of publications in big scientific journals that were really anecdotal. And yet what they described was that patients taking opioids for pain had very low addiction rates. And later on, after that, as that penetrated into the medical community, the American Pain Society decided to become advocates for addressing undertreated pain. And because of the prior opiophobia, there was undertreated pain, especially undertreated acute pain. And so they came up with this banner, "Pain is the fifth vital sign." And this began to percolate through the medical communities, being picked up ultimately by the Veterans Administration in 2000. And then the Joint Commission, in its pain management standards, said that really with each encounter, you needed to address your patient's pain. So in an attempt to both sensitize doctors towards the chronic undertreatment of pain and also get patients a better deal with respect to their acute pain problems. As a result, Medicare eventually picked this up and included it in its reimbursement strategy to hospitals, in that if patients weren't satisfied with their pain treatment, the hospital wouldn't get paid. So people got discharged from hospital very frequently with opioids. And as a result of all of these factors, by 2012, opioid consumption grossly rose from about 47,000 kilograms per annum to 165,000 kilograms per annum, which is a huge increase. So what we've seen is in relation to the increase in the consumption of opioids by the American population, we started to see a rise in the drug overdose deaths involving opioids. And we see here from 1999 to 2017, nearly a six-fold increase from 8,000 in 1999 of opioid-related overdose fatalities to almost 48,000 in 2017. And traditionally, you see men tend to be overrepresented with respect to non-medical use disorders of any drug, and including opioids. So what we ended up with is this epidemic where we first see this marked rise in prescription opioids prescribed and also prescription opioids being used non-medically, with resultant rise in overdose deaths. And then in 2010, approximately, we started seeing a new heroin epidemic. And this is really a critical change in terms of the demographics. In the 1960s, when you thought about people with heroin use disorders, those were typically socioeconomically disadvantaged, typically people of color in urban areas and other economically disadvantaged zones. So people with opioid addiction, 80% of them started with heroin. Whereas when we look at the 2000s, when people started using opioids non-medically, 75% reported their first opioid was a prescription drug. So that's a very important shift in the demographics, and it's predominantly, in terms of the rates of overdose, predominantly Caucasian, although obviously people of color are still represented, but this is a more white phenomenon that we've seen in this latest wave. As of 2013, we've seen a third wave on top of the prior two waves of prescription opioids and then heroin. We are now seeing an influx of synthetic opioids related to opioid overdose deaths in New York State. 80% of the opioid-related fatalities are attributable to fentanyl and its analogs at this point. Net is about 130 Americans die every day from an opioid overdose. So this is just a graphic description of what I just went through. You see the rise in the late 1990s, starting at about 1996, and then the rise in 2010 of the new heroin epidemic, that has a little bit sharper slope than the prescription opioid rise. And then in starting around 2013, a sharper increase in the rise in synthetic opioid related overdose deaths with a much sharper slope. And one of the concomitant drivers of this is that heroin has gotten much less expensive over the last 30 years, about a seven-fold decrease in price, and with a concomitant increase in purity. So again, this would drive, for example, someone who's unable to afford the street price of a prescription opioid pill that they've been using non-medically to shift over to heroin, which is more potent and cheaper. So I mentioned fentanyl. These are mostly coming into the U.S. from illicit labs in China, and then routing through Mexico and other ports of entry, as well as through the U.S. mail. Fentanyl is, because it's so much more potent than morphine, about 50 to 100 times more potent, it's easier to ship and hide in common mail and other delivery systems. We see from 2012 to 2015 in the graphic, 264% increase in synthetic opioid-related deaths across the United States. And it's just going up and up and up. And now we find that people are actually preferring, who have opioid use disorders out on the street, they're actually people who go out and look for fentanyl-containing products. But unfortunately, a lot of those people overdose and die. I might add that one of the other problems with this contamination is that not only is it contaminating the heroin distribution supply, but it has also moved over into the stimulant supply. That was recorded back, I think, in New York in 2014. They started seeing overdose deaths of people who had no tolerance to opioids because they were stimulant users, and they would go out and buy cocaine and then use cocaine and die of fentanyl overdoses. So it's a problem. People don't know what's out there. Most people who use heroin use at least one other drug. You can see that people who have alcohol use disorders are double the likelihood of to be addicted to heroin. If they have a cannabis use disorder, it triples. If they have a stimulant use disorders, it goes up to 15 times. And if you have an opioid use disorder for prescription pain medications, it increases the likelihood of risk of heroin use disorder to 40-fold.
Yeah, Dr. Rosenthal, you pointed out all of these contributory factors to the opioid crisis. In your opinion, if you could point to one particular point in history that most contributed to the crisis, what might that be?
Yeah, I don't think there's a most, but to me, one of the most salient ones is, as I mentioned, back in 2005 when Medicare linked the assessment of pain and patient satisfaction of attention to their pain to the VBP reimbursement. They created what I would call a perverse incentive to discharge patients with opioid prescription. And because there was a hospital level or institutional level incentive. And fortunately, Medicare has rolled that back now and uncoupled that to payments. It's still a quality indicator, but it's no longer coupled to payments. So that's, they figured out that mistake. But it was a powerful perverse incentive.
Dr. Torrington, what are your thoughts? Do you agree with that assessment?
I do, and I think that it's a multifactorial issue but the fulcrum is really right around the year 2000, and there were other factors that most people don't even consider, like the fact that 2000 to 2010 was the decade against pain. We went to war against pain in the U.S. Congress. Right around that time was when the FDA started allowing pharmaceutical companies to advertise drugs on TV. So medication became a commodity that people wanted. Okay. Moreover, a doctor in California got convicted of battery for the undertreatment of pain. In addition to that, there was issues about patients and doctors. Their relationships were dramatically changed right around that same time because of HMOs. And the doctor used to be somebody that everyone knew and was in your, that had been around for years. And now the doctor's the guy at the window. All these things started changing the whole relationship, and all these factors created a perfect storm, which put us in the situation we're in now.
Yeah, point taken. Thank you, Dr. Torrington and Dr. Rosenthal. Dr. Rosenthal, can you tell us more about how substance use and mental health interact?
Sure. So one of the things that we know from decades of epidemiology is that people with substance use disorders have high rates of comorbidity for other mental disorders. And conversely, people with diagnosable mental disorders are at higher risk for the development of substance use disorders. And so that's epidemiologic evidence, and that ends up being, strong associations that are replicable and predictable. The question is that how does that work, right? And because, for example, if we look at depression, we know that chronic pain is common amongst patients with chronic major depressive disorder, and having the depression may actually exacerbate the pain symptoms, right? Similarly, people with chronic pain, about 50% of those people also will develop a major depressive disorder. And so we know that, for example, people with major depression are 2 to 3-fold more likely to develop a substance use disorders than those without chronic pain. The question is, and in both cases, it makes, similar to other comorbidities, it makes the disorder harder to treat. So if you're depressed and you have a substance use disorder that's active, that depression may be more refractory. Similarly, if you have a major depression, your pain may be less opioid or other responsive. Right? So people with depression who have chronic pain will need higher daily doses of an opioid, more days of supply because they need more pills to get to the suppression of perceived pain, and more highly controlled or scheduled to opioids. In one study by the World Health Organization, persistent pain predicted the onset of a psychological or mental disorder with the same strength that a psychological disorder predicted the onset of persistent pain. So what that really means is that, and this is true of other disorders we've been finding out, for example, between cannabis use disorder and the onset of schizophrenia, for years and years, you get these associations without being able to make a causal attribution. What we've now found is that there is a two-way street, that there seems to be what we call bidirectional causality. Okay, that we know that depression is not only associated with an increased risk of an opioid use disorder, but it has a causal role. Similarly, that opioid use is associated with not only increased risk of, but has a causal impact on the onset of depressive disease. So that these two things now are not only linked by association, but they may actually have a causal component. And that takes sophisticated statistical analyses and large enough sample sizes to be able to demonstrate these. One of the other implications is thinking about other mental disorders. And I think it's really important to underscore a hidden factoid in this epidemic. First is that more than half of the people who are current non-medical users of psychotherapeutic drugs, which are about 6 million, 3.2 million of them are current non-medical users of prescription pain relievers. So prescription pain pills are more than 50%, 53% of all of the non-medical use of psychotherapeutic drugs in the US population. In addition, about 16% of US adults have a current mental disorder, yet they receive about half of all of the prescribed opioids in the United States. So it's clearly overrepresented, right? So if you want to do the statistical comparison, it's almost 19% of adults with mental health disorders use opioids versus 5% of the population without mental health disorders, mental disorders, which gives you an odds ratio of greater than double, right? And as a link to that, which I think is really important, people tend not to think about or ask, of the 70,000+ drug overdose deaths in 2017, about 4,900 or 7% were suicides, were intentional drug overdoses. And another 5%, another several thousand, were of undetermined intent, which may include suicide. So there's a significant subpopulation of people who die from opioid-related drug overdoses that were actually suiciding, and it's not been written about sufficiently, and it's not been popularized. So it's an important piece to remember.